Hello, and welcome to the Touch panel discussion, The Practicalities of Eosinophilic Esophagitis Management, a closer look at emerging biologic treatment options. My name is Dr. Nirmala Gonsalves, and I am a professor of medicine in the Division of Gastroenterology and Hepatology and co-director of the Northwestern Eosinophilic Gastrointestinal Disorders Program at Northwestern University, Feinberg School of Medicine in Chicago. I'm joined today by Dr. Sharon Hall, a consultant in pediatric allergy at Imperial College Healthcare NHS Trust, London, UK. She helps to provide one of the largest pediatric joint allergy gastroenterology services in the UK. I'm also joined by Dr. Salvatore Oliva, a consultant pediatric gastroenterologist and assistant professor of pediatrics at the Pediatric Gastroenterology and Liver Unit, Sapienza University of Rome in Rome, Italy. Our agenda today is to review EOE in children and adults. What are the similarities and differences? To highlight caring for children with EOE and how can we manage the transition to adult services. We'll review treating children and adults with EOE and what do the latest data show. So let's start off with the first point, EOE in children and adults. What are the similarities and differences? Let's highlight some underlying mechanisms of EOE development. We know that food allergens, and to a lesser degree, air allergens, drive inflammation in eosinophilic esophagitis. 70 to 80% of patients with EOE have atopic conditions, such as asthma, allergic rhinitis, or atopic dermatitis. This leads to inflammation and fibrotic remodeling and changes we see in the esophagus that lead to symptoms of dysphagia and food impaction. Patients may have a specific genetic profile. Some of those genes lead to impaired barrier function, which can contribute to this inflammation. Microorganisms and the microbiome is also being investigated in EOE. Doing a little deeper dive into EOE pathophysiology and looking at it from a molecular level, we see that in patients who may have some disrupted epithelial barrier, food allergens and air allergens can cross this barrier, be taken up by dendritic cells. Those dendritic cells then trigger homing of Th2 inflammatory cells to come into the tissue. Those cells then trigger other inflammatory cells such as mast cells, basophils, and eosinophils to traffic to the esophagus. Those signals include IL-25, IL-33, TSLP, IL-4, IL-13, and IL-5, in addition to eotaxin 3. When eosinophils are in the tissue, they can break apart, cause a lot of inflammation. This leads to fibroblast activation, collagen deposition, smooth muscle hyperplasia, and hypercontractility, all of which result in the macroscopic changes we see visually on endoscopy, including furrowing, white exudates, edema, concentric rings, strictures, and fibrosis. Moving back from the microscope a little bit, we'll look clinically at what we think happens in this schematic. Patients start off with a normal appearing esophagus. Food allergens and air allergens then trigger inflammation and eosinophils to go to the tissue, leading to inflammatory features of that esophagus. As time goes on, there's more fibrosis deposition in that tissue, eosinophils persist, and you start to see fibrotic endoscopic changes of concentric rings and strictures. As time moves on even further, there's more and more fibrosis, more stricturing and narrowing of the esophagus. We think of this happening as a continuum over time, with children starting off on the left with the inflammation in the esophagus and progressing to the adult phenotype as time goes on. We know that diagnostic delay can lead to greater rates of stricturing, and sometimes this necessitates both anti-inflammatory and dilation treatments in some patients. With that overview, we'll open this up to a discussion and highlight comparisons of the pathophysiology and clinical manifestations of EOE between children and adults. So I'd like to start off by asking Dr. Hall, what is the current understanding regarding the key pathophysiologic drivers of EOE, and do these different factors at play change over time?
So the understanding of the key pathophysiological features in EOE has progressed quite significantly in the last 5 years, with a much greater understanding of the fact that it's a Th2 eosinophilic allergic inflammation with subsequent, as has been explained, fibrosis. The factors that go into that are, as discussed, the heritability and genetics, which has given us quite a lot of insight in potential mechanisms that are involved, and also the genetics, with certain genetic disorders being associated with higher risk of eosinophilic esophagitis. And thinking about those, I would be thinking about things like rheumatoid arthritis, Ehlers-Danlos syndrome, and then rare genetic mutations such as SFNC5 with Netherton syndrome, where you have break in epidermal barrier. And then obviously that leads you into things that control or affect the epidermal barrier, which seems to be key to the pathophysiology. And that disruption of the barrier seems to be part and parcel of eosinophilic esophagitis. Looking at the more cellular pathology, the major drivers are eosinophils and their products, most notably things like major basic protein that affect the epidermal barrier directly as proteolytic enzymes, but also the cytokines involved, which have led to the advances in some of the monoclonal development, such as IL-5, IL-13, and receptor antibody drugs associated with that. But to think about whether the physiological drives are different, initially there was a conception that diet was more important in children, that they responded better, and therefore food allergy was more important. But in fact, subsequent studies have shown this is not the case, and it's probably more to do with the fact that food allergens are a driver with the associated risk associated with atopy, but adults behave differently to dietary restriction and elimination than children do, and so do their carers and professionals in the use of those treatments. So there's a big difference between gastroenterologists in paediatrics using dietary elimination versus adult services, and therefore that seems to have reflected the changes in thought, but probably doesn't reflect a change in the pathophysiology. The major thing that is important in the pathophysiology is the fibrotic nature. So you get the inflammatory response, which you see commonly in children, but in studies it has been shown that some children, the remodeling and fibrosis will settle down with topical corticosteroids, but that tends to be less the case in adults, where the mucosal inflammation will settle, but the remodeling and fibrosis underlying that doesn't change. So very similar to an asthma process where you get initial inflammation, but it builds into that fibrotic pattern of disease and the remodeling, which seems to be more difficult to stop unless stopped early.
Thank you, Dr. Hall, for that excellent allergic overview of the pathophysiology. I will just highlight a couple of points that you've mentioned. Dietary therapy has been much more common in children than adults, but it's been more recently accepted, at least in the U.S., as a form of treatment, and we'll highlight that later in the program. I'd like to transition now to Dr. Oliva to really highlight some of the similarities and differences in the clinical presentation of EOE in children and adults.
It is true that we have quite important variability in terms of clinical presentation between children and adults. The main idea is the younger is the age, the more unspecific are symptoms of this condition. Because when we talk about eosinophilic esophagitis, then we can describe this disease as a disease leading to esophageal dysfunction, to dysphagia, something like that. But in children, this is completely different because the younger children are usually having more unspecific symptoms, such as, first of all, failure to thrive. So up to 30% of children starts their disease with the simple failure to thrive. together with food refusal or with vomiting, regurgitation, and GERD-like symptoms. And the difference between a normal GERD is that we have children not responding to PPI therapy, so this could be a clue of the disease. While when we have older children, then we can have a disease much more similar to the adult presentation. But even in this case, it is possible that we can have a prolonged meal, that we can have a compensative behavior of children that usually start to deal with dysphagia while they can try to compensate the disease. So sometimes this affects the diagnostic process, and we can have a diagnostic delay, significant diagnostic delay in children. So it is very important that we keep in mind that when we have young children, we should consider the right question to the right patient to understand if the disease is present or not.
Thanks, Dr. Alva. And sometimes I feel fortunate that I'm an adult gastroenterologist because I think the adults present a little bit more clear cut than those nonspecific symptoms in the pediatrics, where the most common symptoms in adults are dysphagia and food impactions. But I think you also bring up a really good point that patients who have had this disease for years and years tend to accommodate very well for their symptoms, and they tend to adapt. So they will chew their food excessively, they will drink water with each meal, they'll avoid certain foods. So oftentimes it's not enough to ask patients if they have difficulty swallowing, but really do a deep dive into how they're eating. So that point is very important for clinicians to understand. And the last question I'll kind of open up to both of you is, what do you think are the similarities and differences in clinical and histologic outcomes for children and adults? Do you think one group is more difficult to treat than the other? How do you see treatment changing in these two patient populations?
Adults and children respond to the treatments that are recommended, which is dietary elimination, PPIs, and topical corticosteroids as sort of first-line treatments. And histologically, you see reduction in the inflammation. In children, you might see some resolution if fibrosis is just starting, but in adults, you generally won't. From a clinical perspective, you see symptom improvement in both groups. Obviously, the symptoms of which they've initially presented are quite different by age group, with children tending to present with nausea and vomiting and failure to thrive, and adults and older children and adolescents presenting with problems with swallowing difficulty and dysphagia, but they respond to treatment symptomatically similarly.
Thank you, Dr. Hall. Anything else you'd like to add, Dr. Alva?
Yes, one thing that we can say, and we are lucky as a pediatrician, that usually since the disease is much more inflammatory mediated, then we can have a higher possibility to have an histological response rather than in adults, in which we can have remodeling that can affect the response to treatment in terms of reducing inflammation. So this is something that really happen in clinical practice, and we fortunately can have more effect in terms of histological remission in more patients than in adults.
Thank you for that. And the last thing I'll add, in terms of treating adults, I agree they have much more of that remodeling, the fibrosis, higher degree of stricturing, and oftentimes we'll need to do esophageal dilation for that. But I've been very surprised at how much of this remodeling can actually reverse in adults even. We've treated patients with both topical corticosteroids and dietary therapy, which have been available to us, and seen those strictures improve by at least a few millimeters in diameter just with treatment alone. And studies here from Northwestern have shown, using the EndoFlip, that you can see improved compliance after both dietary and medical therapy. So that fibrosis can improve, and I think you've both highlighted the importance of starting treatment early in younger patients to prevent that fibrotic march. We'll now move on to caring for children with EOE. How can we manage the transition to adult services? A study by Dr. Shuval and colleagues have shown that many patients with EOE are lost to follow-up. This was a retrospective chart review of patients with EOE at a tertiary care medical center. They had 177 patients, 41 children, and 136 adults. And what you can see here is that 39% of pediatric patients with EOE were lost to follow-up, meaning not seen for greater than 1 year. And 72% of adult patients were lost to follow-up and not seen for greater than 1 year. So these findings not only underscore the importance of effective transition of care, but also highlight ensuring that patients engage with ongoing management and follow-up, especially in the adult population. We'll review a little bit of transition of care, both patient and provider responsibilities, and how this changes as the patients age. So when you have younger patients, 11 to 15 years, we'll highlight patient responsibilities and provider responsibilities. So patient responsibilities include that they should know their disease name and medications. The pediatric provider responsibilities include introducing the concept of transfer of care, developing individualized care transition plans, addressing misunderstandings, identifying psychological, social, or economic issues that could pose hardship. When patients are older adolescents, ages 15 to 18 years, patient responsibility includes understanding treatments, procedures, and risk of non-adherence or loss to follow-up. They start to participate in their decision-making. Pediatric responsibilities include ongoing assessment of transition readiness, identify and address areas for improvement, promote self-management skills, discuss individualized care plan and simplified treatment regimens. And here we come up with adult provider responsibilities, with joint review of the patient case and starting to have joint visits with pediatric and adult gastroenterologists, allergists, and dietitians. When patients are 18 years or over, their responsibilities really are to start to assume responsibility for their own care and appointments and prescriptions. Pediatric provider responsibilities include continuing or establishing care with adult subspecialists such as allergists and dietitians, and to discuss the implications of EOE for education and work. Adult provider responsibilities including transfer to adult clinic at this point and assume and continue their care. So we'll now open it up to discussion with Dr. Oliva and Hall. How does care change between children and adults with EOE? Dr. Hall, what is your approach in your practice?
Within my practice, I have a complex joint allergy gastroenterology clinic where the children referred to the service will have been seen by a tertiary allergist and a tertiary gastroenterologist. And they tend to be the children with more complicated disease, not just from a gastrointestinal point of view, but from a multi-system disease. So all of my children will receive a transition which is individualized, and where that is will depend on the balance of their problems at that time, whether there is significant problem with the immediate food allergies or the eczema or the gastroenterology, because whereas within the allergy gastroenterology service, I have the complete luxury of being able to do joint clinics, and therefore the children are seen by an allergist and related specialties as needed, often in joint clinics. That doesn't exist in most adult services, and I then have to refer separately. So certainly one thing that changes is the lack of the holistic MDT approach across the various specialties the children will be seeing. With children who've got less complex disease, the transition arrangements are quite different between different areas, some in the UK being quite advanced, whereas in fact others, the transition arrangements are still being developed and put in place in really following the national guidance and the European guidance.
Thank you, Dr. Hall. And I'd like to talk to Dr. Oliva. As a pediatric gastroenterologist, what are the key challenges you face with transition between childhood and adult care?
I think we should consider that transition is a process, it's not a step. So we need to dedicate time to this process. And we need to start very early in the transition program, in the early adolescence, when the child is still 12, 30 years, because it's important that we need to promote his independence. And this is something that is very complicated for me, because as a pediatrician, we usually have a direct relationship with parents. But during transition, we need to decrease this relationship to increase the autonomy of our patient. And this is not an obvious process. This needs to be understood by the child, but needs to be understood by families, because sometimes they want to keep control of the disease. So it is very important to promote the autonomy of our kids, even if they could not be ready. We need to insist, we need to provide information, we need to involve them in the decision. This makes the idea how much important is that they can be the real player of the disease. They can take their decision, and they need to improve their self-management skills, which are very important when they go to the adult clinic. And I think the more important thing is that even in this process we have problems, then we need to dedicate time together with our other colleagues that need to be present during the process, because otherwise there would be we can lost information over the process.
I think you both have done a great job at highlighting some of these challenges. And as an adult gastroenterologist, I see the challenges on the other side. So we have a large pediatric hospital, and we've been working on a transition clinic. And I think some of the hiccups and the hurdles are when we start having the older adolescents come over as part of this transition in a joint capacity. It's exactly as you say. The parents really who have been taking a very large role up until that point continue to take that role and need to find a good way to step a little bit away and have that older child really try to self-advocate for themselves and, move into that adult space. So I think that's a big challenge. I think another big challenge in an area is when kids go away to college. They've been used to seeing their pediatric allergist and gastroenterologist. They go to college. They're in this nebulous space, and then they come back as an adult, and oftentimes will get lost to follow up in terms of their treatment, and might come into an adult ER with a food impaction, and then all of a sudden transitioning over to adult. So I feel like that's an area that really needs some better transition. And as an adult gastroenterologist, I also feel that we need to do a better job at maintaining those adult patients. I'm sure similar to children, when our adults are doing well on treatment and they feel great, sometimes they stop their treatment and, just on their own, and will come back in with some complications. So I do think that there are challenges, but this transition of care is essential. And having some type of a multidisciplinary approach, as you've both highlighted, is very important. What are the challenges in terms of physical space do you think that you have at your centers? Because I think that's another issue for many practices. Is you highlighted having a multidisciplinary program, allowing both the gastroenterologist and the allergist, the pediatric allergist, and adult colleagues to see them. How can this be managed in the community setting? Some of us in academics may have that already built in, but what is your advice for community practitioners on making this a more effective transition?
From our perspective, in general in the UK, and particularly in my institution, there's difficulties with space. There is clearly not enough space, and often subspecialties won't be working within the same hospital. Children's hospitals per se in the UK are fairly few and far between. So, for example, the paediatric allergy service is run from St Mary's, and the paediatric gastroenterology service is run at a hospital about 3 miles away in Chelsea and Westminster. So even as a paediatric service, we're not co-located at present, although people are trying to make that much more integrated. Then when you try to throw into that mix of trying to bring your adult colleagues into the same space, and they're not necessarily going to be in the same units as you, because certainly your your conversation around going away to university would usually be discussed with our patients first, and we may transfer care to another centre for the period of their university time, or we will arrange appointments in the leave times when they can come back. So one way of overcoming the space and time is starting the transition process early. And I think it's the duty of paediatricians to be thinking about it from 11 onwards and introducing that idea, and to run adolescent clinics before you even get to thinking about joint transition clinics, where you go through the basic skills of transition, which are really applicable to any condition, and then the condition-specific skills that people need to acquire. And you almost need to think about, what do they need to learn at what stage, and have we covered it? Are they emotionally and psychologically ready to do that? And I find it immensely helpful to run evening clinics after school, which are often done as video consultations, because then the children are actually more au fait with the technology than the parents. And that's a really good move to get children interacting. And then obviously engaging adult colleagues and getting them excited about transition, because for me, that period actually extends beyond 18. With allergic disorders, generally, they're most at risk up until about the age of 25 of falling out of the system. So it's actually longer than the 18, 19. It's actually to 25, and getting transition embedded into your healthcare system in an integrated way.
Any last minute comments, Dr. Oliva?
I think that we should also consider that EOE is still a rare disease, at least by definition, even if the disease is much more frequent than we thought in the past. And this makes the process much more difficult in terms of support from our institution, because for IBD, for example, the transition program is available everywhere. For EOE, it's not obvious that we can find a transition program in any hospital. So it's important that any physician that take care of this condition needs to fight for a transition program in their institution.
I think what you both have highlighted is that this is a huge area of need and should be a priority for development of these programs moving forward. Thank you very much. Okay, we'll now move on to our last section, treating children and adults with EOE. What do the latest data show? I'd like to review this clinical decision support tool developed by the AGA for treatment of patients with EOE. So when you have a patient with EOE, they can be treated with either medical therapy or dietary therapy. Medical therapy includes proton pump inhibition, swallowed topical corticosteroids, and as of 2 weeks ago, dupilumab, which was approved by the FDA to treat patients with EOE aged 12 years and older. Dietary therapy includes empiric elimination diet, which is favored over elemental formula or allergy testing-directed diets. If your patients do not respond to either of these options, you can switch paths. Patients with diet can transition to medical therapy or vice versa. After you make these changes in treatment, you should follow up an endoscopy with biopsy to make sure your treatment is working. In patients with a clinically relevant esophageal stricture who have persistent dysphagia, an esophageal dilation should be done. Once you have a patient who's responded symptomatically, histologically, and endoscopically, they should remain on maintenance therapy because we know that these are chronic conditions. So now we'll review the impact of the latest data for emerging biologic treatment options for EOE on clinical practice. Dr. Hall, what are the latest efficacy data for emerging biologics in children and adults with EOE?
Thinking about the emerging biological agents that are available for children and adults, these base back to the discussion we had earlier on the molecules and pathogenesis of eosinophilic esophagitis. And from the mechanistic work, target molecules have been identified, and currently there is work on IL-13 antagonists, on SP1R and IL-5, which is mepolizumab, cendakimab, which is IL-13, and lirentelimab, which is Siglec-8. And then in phase 3 trials is benralizumab, which is an IL-5 receptor antagonist, and dupilumab, which is an IL-4 receptor antagonist and IL-13 antagonist. And dupilumab is the first monoclonal antibody to be licensed for eosinophilic esophagitis in the US. Thinking about the data that allowed that to go forward, that comes from the Liberty EoE TREAT study, and weekly dupilumab versus placebo demonstrated statistically significant improvements in EoE symptoms, with a greater proportion of patients achieving histological remission with an acceptable safety profile.
Thank you, Dr. Hall, for that lovely overview of the emerging biologics in EoE treatment. Dr. Oliva, what are the adverse event profiles for emerging biologics in children and adults?
I think biologics are pretty safe, and this is the same experience we had for IBD, for example. So basically, the dupilumab in the trial mentioned by Dr. Hall was affected just by injection site reaction, which are very small reaction and some cases of fever, but this is very unspecific fever with a short duration. The other biologics are also safe. It seems that some of them can also lead to gastrointestinal symptoms such as vomiting, nausea. There are cases with headache or upper respiratory infection. So, but basically, the biological therapy, as we know from many other conditions, even when we use, for example, the dupilumab for other atopic condition, that these drugs have a good safety profile, so we can use without problem and with very few adverse events.
Thank you for that. I mean, I think this data really highlights the bench to bedside applicability of what we know about with EoE, with all of these things targeting key cytokines that are upregulated in EoE. Now, this is very new data that this was recently approved. So how does this help position some of these biologics for you both in terms of treating EoE in your clinical practice?
From the perspective of an allergist, we already use biologics quite significantly in our practice for respiratory disease and for eczema. And I think that the upcoming biologics, the one that has already been licensed in the US, and some of those other molecules that are in development, which show promise, are going to be useful. I think, like all biologics, we will learn more about which patient we select for which drug as time goes on, and we will hone the biologic we use probably along with their comorbidities, so that you end up seeing response to your eosinophilic esophagitis, but also potentially improvement in their other associated allergic comorbidities. So that is a real bonus for allergists. So certainly my patients with complex multi-system allergic disease who also have eosinophilic esophagitis, for example, eczema, where anti-IL-4 receptor antibody antagonist dupilumab is known to be effective, and you've got a patient with poorly responsive or steroid-dependent disease from eosinophilic esophagitis, then they're going to be a good candidate for putting forward for dupilumab. But as new molecules become available, some of them may be more beneficial in some of the other atopic diseases, and I think that will result in much more precision prescribing medicine.
Absolutely. Dr. Oliva, what do you think about for your pediatric patients?
I usually consider biologics now after a failure of first-line therapies, which means PPI, topical steroids, and diet, and even sometimes a combination of them, because when we don't have a remission, we should consider even a combined therapy. We don't know if a combined therapy is the right choice because we cannot consider dupilumab in Europe for patients younger than 12 years. But again, as soon we will have available this drug, this would be possible to consider after one therapy failure, or if the patient is intolerant to PPI, for example, because we need higher doses of PPI to maintain remission, then it would be useful to use a biologics instead of a standard therapy. And possibly in the next future, when these drugs will be completely available on the market, then we can consider this molecule in the very beginning, so we can also consider, for example, in severe diseases, in the early phase of the disease, to halt the remodeling and the process. So I think even naive patient in the next future could be considered for biological therapy when we will have more data on that.
I agree with both of you. As an adult gastroenterologist, we see a lot of patients who are refractory to many of the standard of care treatments, and these agents really offer this opportunity to get to more systemic therapy. And this is very exciting for the field to have the first FDA-approved medication, but also to have many other things in the pipeline, which can also hopefully serve our patients well. So thank you both for this discussion.